These great surgeons, let's have some preoperative chapter together because it's very important in the exam, whether the perioperative or the postoperative, as well as the surgical technique and skills. They are overlapping chapter and frequently asked in the exam. So let's take care from those chapters specifically. And better to read them from several sources to gain more knowledge and train on them during your practice. Please, great surgeon, take care what anticoagulant you are using because the unfractionated heparin is generally cleared from the circulation within 2 hours. So this will allow plenty of time, and in this method of choice in elective setting, the protamine sulfate will reverse the heparin but is associated with the risk of anaphylaxis and thus not generally used unless immediate reversal of anticoagulant is needed, like coming off a bypass. So, stopping heparin infusion 6 hours preoperatively will be sufficient even for patients with metallic heart valve uh, require any surgery, like paraumbilical hernia, for example. It will only be required to stop the heparin 6 hours preoperatively. We all agree that protamine sulfate is the antidote for heparin to reverse its action, and we all know that the lidocaine is reversed by the intralipid. So let's be familiar that the flumazenil antagonizes the effect of the benzodiazepine by competition at the GABA binding site. So flumazenil antagonizes the effect of the benzodiazepine by the competition of the GABA, and protamine sulfate antagonizes the heparin, and we have the intralipid for lidocaine. And of course, we are familiar that methylene blue is antidote for prelocaine, which is pretty important and very commonly used in Pierre's block for hand. These great surgeons take care. Wound healing is very important to every surgeon, whatever your specialty is. It's your life as long as you are a surgeon. Surgical wounds are either incisional or excisional, and either clean contaminated, or even dirty. Although the stages of wound healing are broadly similar, their contribution will vary according to the wound type. And of course, the hope and the dream of every surgeon to have a scarless operation. So, what does make a scar? We have stages for wound healing: hemostasis, inflammation, regeneration, and remodeling. And the only scarless operation will be the fetal surgery operation. It will be totally scarless. And the scar is the inevitable end stage of the wound. So, what are the main stages? It will be first the hemostasis within minutes to hours following surgery, vasospasm in adjacent vessels, and platelet blood formation and generation of fibrin-rich clot. This is the first stage. From hemostasis, we can go to inflammation, regeneration, and remodeling, and they don't take care in order. They can come together concurrently together, but roughly, inflammation typically takes place from the very first day to the fifth day, and regenerative phase occurs from the seventh to 2 months post incision, while the remodeling takes place from the 6 week to 1 year, taking the care of the wound, remodeling, and making the final touches of the scar. You have to be aware regarding your exam to the day it usually occurs and take care of the main cell which contribute in this phase. So, for example, you have been familiar that hemostasis, you can find that platelet blood formation is a mainstay within the hemostasis, and this is important within minutes to hours. While the inflammation occurs from the first to fifth day and the neutrophil migration into the wound. So, macrophage, fibroblast, coupled matrix regeneration, and clot substitution in the inflammatory phase, while in regenerative phase from the very first week to 2 months, you can find that the fibroblasts produce collagen, and this is the mostly the mainstay cell within the regenerative phase. While in remodeling, you have to know that myofibroblasts is the main cell important in remodeling from the first month to 1 year. So you can see the overlapping between the three phases, the inflammation and regeneration, and as well as the remodeling phases, to be familiar with them. The remodeling phase is important because it's the longest phase, takes from 1 month to 1 year. It's the healing process and causes the wound scar to be better. And during this phase, the fibroblasts become differentiated into myofibroblasts, which is the main cell, taking override and taking the upper hand. And this facilitates the wound contraction. Contraction is good thing. Contracture is bad thing, while contraction is good thing. Collagen fiber are remodeled and microvessels regress, leaving a pale scar. So the scar, as we all agree, this is the end stage of any wound, but there are problems with some scar, like hypertrophic scar and keloid. The keloid exceed the wound limit, while the hypertrophic scar respect the wound limit. So the keloid is little bit challenging than the hypertrophic scar, and it resists to surgical excision. While hypertrophic scar, you can re-excise and do revision for your scar. While the keloid, you have to do several modalities to treat with keloid, from silicone sheeting and intralesional steroid injection. And if you have to take care with surgical choice regarding the keloid, you have to trick your body and do intralesional keloid excision, where you leave a rim from the keloid within the wound edge, because if you remove the whole keloid, it will reoccur and come back with even more aggressive keloid. So keloid is treated with intralesion steroid injection, silicone sheeting, silicone gel, as well as compression garments. You can even go with radiotherapy in some resistant cases. So take care of keloid. And by the way, keloid is very common to occur post-burn. Take care from them. Keloid and hypertrophic scarring are defective wound healing. The hypertrophic scarring is better than keloid, and they respect the wound margin, doesn't exceed the wound margin. Good day, this great surgeon. Let's continue together our important chapter, preoperative chapter, as we all agreed on, and it's a very important chapter for MRCS and for your own practice. Regarding warfarin, warfarin is an oral anticoagulant which inhibits the reduction of vitamin K. And by the way, warfarin, by reduction of vitamin K to its active hydroquinone form, which in turn act as a cofactor in the formation of clot factor 2, 7, 9, and 10. And remember it by 1972. 1972 referred to factor 2, 7, 9, and 10. Remember 1972, it's not 1, it's 10. So it's 10, 9, 7, and 2. And of course, protein C. All of those are affected by warfarin. And by the way, warfarin importance not only in its action, but in its drug interaction, because warfarin has many drug interaction. So take care what drugs you are prescribing with the patient taking warfarin. We all know that warfarin before the operations are shifted to heparin 5 days before the operation. And by the way, from the very famous drugs that interact with warfarin, let's take them as what potentiate and what decrease, what potentiate and what inhibit. From the very famous drugs that potentiate the warfarin effect is the diltiazem, the ciprofloxacin, cimetidine, even alcohol. So take care. The fish oil and fluconazole, the antifungal fluconazole, potentiate the INR by potentiation the warfarin, and this is a little bit risky. So take care. Many drugs are potentiating the warfarin effect, so keep them in mind. Again, ciprofloxacin, diltiazem, erythromycin, even fluconazole, even alcohol. Keep those in mind. But what can inhibit? The barbiturates mostly will inhibit the warfarin, as well as rifampicin, which causes red urine, will cause the warfarin to be red and inhibit it. And of course, the vitamin K is the inhibitor and the reverser of warfarin. Many drugs potentiate and many drugs inhibit. We just spotlight the most common to be used and most common in the exam, but you can read them from time to time, like metronidazole, which is antifungal. The metronidazole, which is anti-anaerobe, is very famous to be potentiating the warfarin, and even the omeprazole for the peptic ulcer as proton pump inhibitor is potentiating the warfarin. So take care from them. Metronidazole, omeprazole, even ciprofloxacin. Take them in consideration while prescribing warfarin. To sum up again, the drugs that interact and potentiate the warfarin effect, like ciprofloxacin, the diltiazem, beta blocker like propranolol, and even the proton pump inhibitors like omeprazole, even the anti-anaerobe like metronidazole, keep them in mind because they are all potentiating the warfarin effect. Even your friend, if he is drinking a simple cranberry juice, عصير التوت البري cranberry juice، عصير التوت البري أو كريز، it will affect and potentiate the warfarin effect. And why we are all concerned with the potentiation of warfarin? Because the side effects are unpleasant at all, hemorrhagic and teratogenic, as well as causing skin necrosis. Very specific look to have a patient with warfarin toxicity. Take care, it's very specific. Because skin necrosis, when warfarin is first started, biosynthesis of protein C is reduced. This results in a temporary coagulation state after initially starting warfarin, normally avoided by concurrent heparin administration, and thrombosis may occur in venules leading to skin necrosis. And no one wants skin to be necrosis, even for a patient or a relative. Keep it in mind and keep the drug interaction with warfarin and any drug had any interaction in mind. Let's move on to analgesia and anesthesia. Regarding the anesthesia, it made a breakthrough in medicine because before there was no analgesia and no anesthesia, and the only skill that the surgeon can obtain is being fast. Even one surgeon has cut off his assistant hand because he want to be fast while amputation of the patient gangrenous limb. It was brutal. But thank God, I don't believe any one of you had lost any toe with while helping or assisting in any surgery before, right? So, from the very famous nowadays anesthesia methods is the caudal anesthesia. The caudal anesthesia is a block of the sacral and lumbar nerve roots. This technique is very popular in pediatric patients. The S5 process are the remnant and form the cornea, which provide the main landmark for identifying the sacral hiatus. The hiatus is covered by the sacrococcygeal membrane. The canal contains irregular connective tissue like fat, sacral nerve, and lymphatics, even the filum terminal and reach venous plexus. So, the caudal anesthesia indications of caudal anesthesia would be surgical procedure below the umbilicus as an adjuvant to GA. Dull anesthetic technique in fully awake premature infant younger than 60 weeks of post-conceptional age. The contraindication of the caudal anesthesia are the major malformation of the sacrum like myelomeningocele or open spina bifida, so keep them in mind. Meningitis, of course, is contraindication for any spinal anesthesia and intracranial hypertension. Now don't confuse the spinal anesthesia and the extradural anesthesia. There is a big difference between the spinal and the epidural. The spinal anesthesia level below L1 and L2, where the spinal cord ends, and the injection subarachnoid space, where we puncture the dura mater. Identification of the subarachnoid space when the CSF appears, and the doses are 2.5 to 3.5 bivacine, 0.5% heavy. The onset of action in the spinal anesthesia within 2 to 5 minutes, and the density of the block more dense, and the hypotension is very rapid, as well as the headache is probably a complication. While in the extradural anesthesia, with the epidural anesthesia, the level at any level of the vertebral column, where we injection the epidural in the epidural space between the ligamentum flavum and the dura mater. There is no puncture to the dura mater, and the identification of the peridural space using the loss of resistance technique, but there is no CSF here to appear. Doses are about 15 to 20 millimeter from bovecine, very high dosage, while in the spinal it was 2.5 to 3.5, here 15 to 20 millibovecine, and the onset will be 15 to 20 minutes, while the onset of action in spinal anesthesia was 2 to 5 minutes. And the hypotension risk is low, and the headache is not a probability with the epidural anesthesia. By the way, the layers traversed by the spinal needle while spinal anesthesia are very important, starting from the skin to subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, dura mater, subdural space, arachnoidomater, and subarachnoid space. So we have the ligamentum flavum just before the dura mater and after the interspinous ligament. Keep this in mind, and those layers are very important. From the skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, and dura mater. Very important. So ligamentum flavum is the last layer before dura mater. And this is a cut-off between the spinal and the epidural. Epidural between the ligamentum flavum and the dura, while the spinal is after the dura. Now, many of you think that they can do anesthesia and get rid of their anesthesiologist and keep the fees of the anesthesiologist for themselves. But believe me, the risk and the medical legality of anesthesiology is not for you, surgeon. You are not free to go to the police station. Your anesthesiologist is free to go there. So don't do anesthesia and make the anesthesiologist do it for you. Yes, great surgeon. Regarding analgesia in MRCS and your practice is very important and very critical to follow the ladder. We have a reconstruction ladder, and in analgesia we have a pain management ladder. So regarding the pain management ladder, we start step 1 with paracetamol to control the pain. If no response, you can add non-steroidals. If not respond, you can use weak opioid. Then go for strong opioid if you take all the steps of the ladder and didn't follow. So start paracetamol, non-steroidal, weak opioid, then strong opioid. Take care regarding the analgesia and pain management for cancer prostate. In cancer prostate, we have two main stems: the young healthy patient with cancer prostate or the old patient with cancer prostate. In a young healthy patient with cancer prostate, go for radical prostatectomy. While in old patient with cancer prostate, we have three main stems. If the patient is asymptomatic, then there is no need to perform any surgery or give any treatment, because the patient will not die from prostate cancer. He has many reasons to die from, and don't make your operation one of these reasons. Make the patient die in peace. But if there are obstructive symptoms or meds, but the scenario doesn't state pain, then go for hormonal therapy. So again, cancer prostate in old patient which is asymptomatic, leave the patient die in peace. But if there are obstructive symptoms or even METs without any pain in the stem of the question, go for hormonal therapy. But if the main problem is pain due to METs, then follow the ladder. And if the ladder didn't work, then it's go for radiotherapy. Understand these basics of cancer prostate, and you will find the one in the exam and you will answer clearly. So, for example, patient suffering from a pain for whatever reason, how to deal with him? Follow the ladder. Go for paracetamol. Then, if he didn't respond, non-steroidal. If he didn't respond, weak opioid. If he didn't respond, give him a strong opioid. Another example, if a patient with a bone pain and you have given paracetamol, what to do next? Yes, go with the ladder, non-steroidal, after the paracetamol. Another stem, a severe pain due to bone metas. You have a bone metastasis, not controlled by medication. Go for radiotherapy. Why? Because the ladder isn't effective anymore here. Another stem, a patient have a back pain due to pancreatic metastasis. What to do? Go for the ladder with non-steroidal. Another stem, a patient have severe back pain due to pancreatic metastasis that the patient can't tolerate. Go for celiac block. Why? Again, the medication aren't effective anymore here. Hope those stems make you understand the pain management ladder with examples. Now let's discuss a very critical important question in the exam regarding feeding. An old man recovering from a stroke, but he is unsafe to swallow. And apart from his cardiovascular angioplasty, his past medical history include rate controlled AF, so is a high risk patient. And he had a little operation called oesophagostomy. He has his esophagus removed. Oesophagostomy. He has his esophagus removed. So he can undergo a big tube insertion. However, an esophagectomy will preclude this, as the stomach will now be intrathoracic. So it's better to be doing for the patient a surgically inserted feeding jejunostomy, because he is a human being, and better to start feeding rather than giving the patient total parenteral nutrition via any access. So give the patient food by jejunostomy, and because he has done esophagectomy, he can't do back tube, whatever the route, either endoscopically or surgically. Of course, back tube is better to be endoscopically, but the patient has no esophagus and the stomach is intrathoracic, so there is no need for back tube now. We have to do a feeding jejunostomy tube. So please give the patient an oral intake whenever possible. If the patient is safe to digest his own food and has oral intake, it will be more better for the patient enhanced recovery. It's the easiest option and may be supplemented with calorie rich dietary substance that can't be easily substituted in the TBN, but may contraindicated following certain procedure where the patient is unsafe to swallow. The other option will be the nasogastric feeding, and this will facilitate giving the patient a food as well, but it's usually administered via fine pore nasogastric feeding tube. The complication relate to aspiration of food or even misplaced tube in the lung. And by the way, you need your food to reach the stomach, not the lung. The lung eats oxygen, doesn't eat food. Take this in mind. So, the nasogastric feeding must be taken in consideration in the patients that can't have oral intake as a next option. They often contraindicating following head injury due to the risk associated with the tube insertion, because if the patient have skull base injury, you don't want to give the nasogastric tube to be inserted in his brain as well. Now, the nasojejunal feeding. This avoids the problem of feed pooling in the stomach and even lower risk of aspiration. The insertion of feeding tube are more technically complicated. It's easy if done intraoperative, but in the ward it's more complicated. Safety use following esophagogastric surgery. And it's very common, by the way. The feeding jejunostomy, the surgically sited feeding tube. Because if you are not challenged to do the nasojejunal feeding, you can bypass the nasojejunal feeding and do it surgically sited and maybe used for long-term feeding if you are suspecting the patient to need it for a long time. And there is a low risk of aspiration because you are putting the tube by yourself within the jejunum surgically. So there is a low risk of aspiration in long-term feeding. And the main risks are those of tube displacement and peritubar leakage immediately following the insertion, which carries a risk of peritonitis. And at last but not least, the percutaneous endoscopic gastrostomy, the big tube. It can be done either endoscopically or percutaneous tube in surgical insertion. It may not be technically possible in the patient who can't undergo successful endoscopy, like the patient who have done esophagectomy. The risk include aspiration and leakage at the insertion site. And if the patient can tolerate feeding by any means for any GIT contraindications like Crohn's disease after several operations and several fistulas, you have the patient to be following a total parenteral nutrition to give the bowel a rest. The definite option in these patients in whom enteral feeding is contraindicated, you will be using the total parenteral nutrition. And it's individualized, prescribing and monitor is needed. So it's individualized each patient according to his needs, and prescribed and monitor is needed to the prescription of the total parenteral nutrition. It should be administered via central line as it's a strongly phlebitic. So if you choose to give a total parenteral nutrition, can you give it via peripheral line? It's not advised. It should be administered via central vein. The long-term use is associated with fatty liver and deranged liver function tests. And by the way, total parenteral nutrition can make the patient go to acalcular cholecystitis, by the way, as a technical issue. Take this in mind. Hope the nutrition is now clear within your mind. So, from the very famous scenarios in the exam, a patient with perforated esophagus, what will you do? Give him a total parenteral nutrition, of course. There is no way the patient can tolerate any feeding. We are feeding here from any aspiration. A patient with cardiovascular angioplasty that can't eat safely, go for big tube, which is percutaneous endoscopic gastrostomy. Another scenario, a patient undergoes esophagectomy. He removed his esophagus. Of course, go with jejunostomy. A patient with pancreatitis, with poor appetite. What to do? Go for nasojejunal. A patient with a cardiovascular angioplasty and history of esophagectomy, like the scenario we have talked about earlier. Of course, jejunostomy. So again, what to do with a patient with severe head injury, comatose, no signs of skull base fracture? If there is no sign of skull base fracture, go for nasogastric tube, and this is the trick. Yes, he has a head injury. Yes, he is comatose, but there is no sign of skull base fracture. There is no fear of nasogastric tube. But early rehabilitation of the patient and giving the patient the full need of the body nutrition will enhance his recovery. So go for nasogastric tube. Another scenario, a subtotal colectomy with poor appetite. Give him a nasogastric tube feeding. But a patient with high output fistula, go for TPN. A patient with multiple fistula with Crohn's disease, go for TPN. So, perforated esophagus, or high output fistula, or even Crohn's disease with multiple fistula, go for TPN. A patient he has done esophagectomy, go for jejunostomy. A patient with major operation requires prolonged feeding like cardiovascular angioplasty that can't eat safely, go for big tube. Hope this made it clear. Another thing to mention regarding the patient control analgesia not to forget about. The patient and administer to themselves their own intravenous analgesia and titrate the dose to their own endpoint of pain relief using a small microprocessor controlled pump. Morphine is the most popular drug used within the PCA, the patient controlled analgesia. It has revolutionized the private practice, and I recommend it to be used even in the national hospitals. It's very important to pain relief. We doctors were made to make the patient live with dignity, live without pain, and die with dignity if it requires. So, analgesia is important thing. Never make the patient suffer. Nobody want any suffer. Dear great surgeon, take care from the question asking you. He is asking you after the operation or during the operation or before the operation. In any question, he is asking you about analgesia after the operation. You can't do a tap block after the operation. The tap block is administered during the operation. After the operation, you go for pain management ladder or even the patient control analgesia infusion. Epidural or spinal will provide the patient with analgesia, but this is anaesthesia during the operation. After the operation, if the question asking you after the operation, no one is done doing spinal or epidural for analgesia after the operation. After the operation, you go for an analgesia ladder. For example, all the gynecologists and obstetricians now they promote they have a pain-free cesarean section. This is the tap block with the PCA combined. The tap block is intraoperative, while the PCA, the patient controlled analgesia, is after the operation. Keep this in mind and don't be tricked with the words. So it's important to know the side effect of everything you give your patient and the drug interaction, because you don't want this lucky patient who have warfarin and you give him for a simple wound ciprofloxacin and you go explain to him ciprofloxacin, metronidazole for the anaerobe, and I will give you omeprazole to keep your stomach be safe. It's a proton pump inhibitor, and you go explain without caring for the warfarin side effects. They will potentiate the warfarin and make the INR in fire with the ciprofloxacin, metronidazole, PPI, and the patient will be on fire in INR. You will give the patient for a simple wound a whole skin necrosis all over his body. And he will be the lucky patient that you will greet him with generosity and you will give him a cranberry juice or mango juice to give the patient to hell with skin necrosis from the simple suture you have made, because he was lucky enough to meet you, and you will give him ciprofloxacin, metronidazole, as well as omeprazole for his wound. Will he be lucky enough that you will give him propranolol to give him a nice calm down and his palpitation be calmed out? This patient will not calm when he has skin necrosis. So keep in mind, the drug interaction is important. Even a simple mango juice is important. A simple cranberry juice important, and they interfere with the warfarin and potentiate its action. So the INR is not only the problem he will bleed to death only. No, he will have a skin necrosis. So take care and keep it in mind. Yes, I know you are eager surgeon to suture your patient and give him a well care, and you are generous enough to give him a juice. Give him a cup of water. This will be safe. And another one, He doesn't know that rifampicin is contraindicated with warfarin and given with caution because it might give him an inhibition for the warfarin. So take care. This is the scenario in real life. The patient will come to you, ask him about his age, his sex. Don't ask him about his sex, but keep it in mind, okay? If he is taking contraceptive pills, sorry, if she is taking contraceptive pills, I don't know. By the way, can a man take contraceptive pills? Yes. Search for it. For cancer prostate? Yes. Keep it in mind. We'll talk about it later. Okay? So take care. The drug interactions are important. The rifampicin causes red urine. You have to tell the patient that he might have red urine from giving him rifampicin. But this is not only the case. He might be taking warfarin for anticoagulant, lung support. So don't give him rifampicin with warfarin. Otherwise, it will inhibit the action of the warfarin. And by the way, giving the patient multivitamins, including vitamin K, while taking warfarin, this will inhibit the action of the warfarin. And keep in mind that antifungal like fluconazole must be taken care of even it's given once per 2 weeks or 3 weeks. Once per 2 weeks or 3 weeks, this will affect the warfarin. So keep it in mind. And it will be funny that the patient, you take care of the warfarin and the drug interaction with all the drugs we have mentioned, and you will decide to give the patient an aminoglycoside like gentamicin, and forget the dosage and the toxicity of the gentamicin, that it's ototoxic and nephrotoxic, and the patient will come to you after 2 weeks of having a loading dose with gentamicin, can't hear you, and will go for dialysis because you have made the patient nephrotoxic. He will not be and can't hear. All of this because simple drug like gentamicin. Keep those all in mind. Hope those explained it a lot for you. So always remember that the sodium cypentoin is cardiotoxic. The etomidate causes adrenal insufficiency and causes adrenal killing. And remember, the ketamine, which is very famous to be used by Dr. House for his own pain, causes dissociative hallucination and nightmares. Even Dr. House had nightmares. Hope this be your happy dream in your exam when you have this question and you can answer it correctly. In preoperative chapter, you have to be concerned with preoperative preparation of your patient and concerned with each procedure. Some procedure like endoscopy requires some concerns. Endoscopy is a procedure that allows the internal visualization of the viscera. You will literally visualize and see the viscera from inside via your endoscopic camera. Commonly performed procedures include gastroscopy, colonoscopy, cystoscopy, or even ERCP and bronchoscopy. All of those use camera and imaging for visualizing the viscera. It's a different form of laparoscopy as it's different from laparoscopy. Take care. Laparoscopy is not the same as endoscopy. Endoscopy is within the lumen, but laparoscopy is within the abdominal cavity, as it doesn't usually involve an inspection of the visceral cavity. Laparoscopy can't go through the lumen, but within the abdominal cavity itself. While the endoscopy, you are going through the lumen of the esophagus, in the lumen of the anus, in the lumen of the colon. Endoscopy is within the lumen. The laparoscopy is within the peritoneum cavity. And by the way, most of the endoscopies are flexible instruments with 3 channels and video chip with illumination source at the end. The channels are used for suctioning, irrigation, and instrumentation, by the way. So you can do even surgeries by endoscopy. And many surgeries are done now via endoscopy, not only taking specimen. With the flexible instrumentation, there is a control stack that wheel that allow the tip of the instrument to be manipulated. So some procedure call for the patient sedation and other doesn't require any sedation. Endoscopies should usually be performed in dedicated units with appropriately trained staff. You have to be operator dependent because the endoscopy is requiring a high training technique. And for resuscitation facilities must be available. So don't do endoscopy inside your clinic. It is still an operation. And the preparation of the endoscopy depends upon the organ to be examined. So, the ERCP require clotting antibiotic vitamin K if jaundiced, because ERCP is done if suspecting CBD obstruction, like common bile duct obstruction, and we'll talk about this later in the hepatobiliary chapter. So, regarding the diagnostic esophagogastro diagnosis, he has to be nil by mouth for 6 hours. The flexible sigmoidoscopy. This is a simple procedure which only requires phosphate enema 30 minutes before the procedure. So you just go to your facility and 30 minutes, it's your way. You have to do your phosphate enema and you can do the flexible sigmoidoscopy. While colonoscopy, you have to check the electrolyte imbalance and the ureate, by the way. And if normal, you can prescribe oral purgative like Bicolax and go for the colonoscopy.